Okay, welcome everybody to this webinar of the Global and Humanitarian Committee of the EANS. We're going to talk to you about twinning programs. We have three excellent speakers from different parts of the world, and I think that would be interesting to kind of understand what the issues are and how people are resourceful in these challenges and opportunities as well. So we are going to start with a presentation of Jamil, who is also part of our committee. He's from Russia. Thank you for being here. And he is partnering with Dr. Dugun, who is in Mongolia. So I am very, very intrigued how this partnership is going and what you all have to tell us. So yes, please start.
Thank you, Dr. Elian, for kind words and warm introduction. I'd like to thank Dr. Lilian Rubio for the opportunity to share my humble experience in this. Just a moment, yeah. At such a first-class EANS webinar. This is my disclosure. My topic is not a completely scientific topic, or to be more precise, not scientific topic at all. And before organizing this webinar, I asked Elian, maybe do you remember what twinning program means? And Dr. Elian explained for me that a twinning program is a cooperation between two countries, and the cornerstone of this issue is sharing of knowledge. Perhaps we don't meet some points of this definition, but in general, to my mind, the collaboration with neurosurgical colleagues between our facility and some neurosurgical departments from overseas countries is so deep that it meets this definition. Novosibirsk locates here in south of Western Siberia, and you can see this conjunction of four state borders: Kazakhstan, Mongolia, Russia, and China. And our facility, Novosibirsk, here is accepted for patients from this vast territory, this huge territory, this east part of Russia. And this does not mean that there is no neurosurgery except us in this huge area. Not at all. In any large city, there are some neurosurgical departments that perform excellent surgery. But we can collect some challenging patients and cases from east part of Russia. Our facility has been working since December 2012. Our neurosurgical hospital, I mentioned before start of this this webinar, is quite unusual facility, not only for Russia. I have not seen many such kind of only neurosurgical hospitals in other countries too. And the main idea behind the building erection of such a highly specialized hospital is to make expensive neurosurgical treatment more accessible to people living in remote regions of Siberia. We performed about 4,500 surgical procedures annually, and we have six ORs for open surgery and 2 ones for endovascular procedures. And this structure of our hospital, we have 5 divisions: pediatric, spinal, neurovascular, neuro-oncological and division of functional neurosurgeries. It's not common, at least for Russia, this specific division for functional neurosurgery. And briefly about each division. In the pediatric division, we performed all kinds of pediatric neurosurgical procedures, about 300 cases per year. And as in other neurosurgical departments of the world, spinal division performs the largest number of surgical procedures. And in neurovascular division, in this division, my colleagues performed nine hundreds of different kinds neurosurgical, vascular neurosurgical procedures, including open microneurosurgery and endovascular technique. And in the neuro-oncological division, approximately the same number of procedures as in the neurovascular department. About, sorry? Can I go on? Okay. And this is the last division, unusual, as I mentioned. In this division, we perform some poor functional procedures as DBS, Marmot disorder treatment, microvascular decompression, and including some peripheral nerves surgical procedures. And advantages of our facility that we can collect many challenging cases, and this consequence of the possibility to study. And this in turn makes it possible to engage in scientific activities. Also, in hospital where I work, there are 3 labs. One lab for practice of basic skills, for micro sutures, for some drilling, etc. And the second one for cadaver, skull-base dissection, transnasal, different hands-on courses. And the last one, the spinal lab, this well-equipped lab for using X-ray. The walls of this facility lead protected, and inside this room we have some specific protection aprons, etc. And our hospital has wide international partnership connections. In the years, our facility was visited by guests from many foreign countries, and our hospital is visited by residents, observers, and fellows from different countries, not only from the countries of Central Asia, but also from Mongolia, which we will talk about a bit later, not only from neighboring countries, but also from distant countries, from the South Caucasian countries. And we can provide visa support, and we can pay for modest housing, not luxury, of course. And our visitors, residents, fellows, and observers can scrub and work in labs available almost 24 hours a day. And doctors from our hospital visit these countries for delivering lectures, conducting workshops, and holding hands-on courses, and performing surgical procedures at all. But instead of summary, I finish. Despite we have some advantages to invite young colleagues taking the participation in our educational events and activities, of course, we have some troubles in this practice. And the issue is especially we cannot share and to ship equipment like in other twinning programs. And now the last 3 years, we have some limits for limitation for direct flights to Novosibirsk because from Western countries to reach Novosibirsk is possible just via Istanbul and Dubai. And we are members of the global neurosurgical family and must support each other. I went a little over my time. Perhaps my co-author and colleague, Dr. Dolgun, can tell you better than me. Thank you for listening to me.
Thank you, Jamil. Let's continue with the second part of this first presentation, and at the end we do questions. Go ahead, Dr. Dogun.
Well, can you see the presentation?
Yes.
Well, okay. I'm very glad to continue the lecture. Thank you, Jamil Fetovich. So I'll be talking about transforming challenges into opportunities between Mongolia and Russia. Again, my name is Ganbato Dilgun. I'm a resident at the Federal Center in Novosibirsk. Well, first part of the presentation, I'm going to be talking about Mongolia. It's 604,000 square miles with a population of 3.5 million people. Well, it borders only with two countries, Russia and to the east, China. And medical service in Mongolia is a challenge because there's very long distances between towns and nomad lifestyle and the low population density in the vast territory. Well, mostly it looks like that. And it is Ulaanbaatar, the capital of Mongolia. Well, I believe it is a good idea to say a few words about the founder of the Third State Hospital in Mongolia, Pavel Nikolaevich Shestin. He's Russian from Siberia, who played a significant role in the development of modern Mongolian medicine. And he's known for founding the European Hospital in Mongolia in 1925. And the construction features illustrate the building's transformation through the years. And on the last picture, it's the front view of the hospital.
Can you put your slide in because we're not seeing your slides. Can you put it in full view?
Yeah. Oh, I'm sorry.
If you put it in full screen, then it will probably do it. Or you need to do the slideshow by hand. Yeah.
Now, can you see it?
We see your presentation, but not in the slideshow.
Oh, strange. Well.
If you go back to sharing the PowerPoint presentation, probably on the right lower corner, you can put it on presentation mode.
Well, can you see it okay? Or is it still?
We see your presentation, we see your PowerPoint, but you have to click on the slideshow. At the bottom of the PowerPoint presentation?
Here.
Yes, exactly.
Here. Here.
Okay, that's good.
Not yet. Not yet.
Oh, strange.
That should open into another window, so you need to go and share the new window.
I actually
Your
did that.
slides need to go in a new window, so you go and share that window.
Well,
Okay, here. Давай.
is it okay right now?
Not yet. Not yet.
But otherwise, just click forward through the presentation. To go to the slide you were,
Mm-hmm.
Yeah.
just click with your mouse. We can follow it.
Okay. Well, let me walk you through a brief overview of the history and development of Mongolian neurosurgery. About Jalal Hedula, he is recognized as the founder of neurosurgery in Mongolia. And in 1965, he finished his neurosurgical fellow in Czechoslovakia and established the Department of Neurosurgery in 1971. Here we may see today's members of Department of Neurosurgery.
We can
And
still only see the first slide. Yeah, now it's working.
okay.
Okay.
About the service, the third state hospital provides neurosurgical care for majority of the Mongolia, more than 80%, in the Shastin's Central Hospital. And since 2020, with the sponsorship of the Asian Development Bank, the number of surgical equipment has increased, and so increasing the variety of operations to be performed too. About statistic, past several years, number of surgery has increased, and last year was performed 2,072 operations, and mostly it is intracranial aneurysm clipping and brain tumor removal and spinal surgery. On this slide, we see members of Society of Neurosurgical Interventional Surgery. And in the middle, here's my father, president of Interventional Surgery Society. And for the first time, they started performing neuroendovascular procedures since 2014. And 2022, they established Mongolian Society of Neurointerventional Surgery. The numbers of neuroendovascular surgeries is rising consistently too. Recent years, we actively work and develop international partnership and cooperation. And here's shown one of the ongoing international study of 20 clinical centers in Russia, Mongolia, Kazakhstan, Kyrgyzstan, and South Korea. And here starts my second part of my presentation. Here we see our residents in the center, and some of them are our neurosurgeons, our mentors. Well, those are my pictures. Here we see we can practice and train our basic surgical skills such as endoscopic and microsutures and craniotomies. And practical hands-on training sessions are common here too, and conducted by professors from our center or experts from other Russian cities and foreign universities. And I'm very happy to say that I'm able to learn from high-skilled neurosurgeons and to see how they deal with rare, challenging cases and observe high technological advanced technologies such as AR and exoscope. The center promotes and encourages all aspects of neurosurgical practice and continue education and advancement of this discipline. And there's pretty often arrivals from abroad and conduction of workshops, international congresses and conferences. And cited here Dr. Ilian about the tuning program. And I'd like to talk how it relates to us in my understanding. And firstly, this year we are planning to organize a conference in Ulaanbaatar and intend to invite members of Siberian neurosurgeons to participate, of course. And secondly, upon completing my residency and returning to work in Mongolia, I look forward to closer ties and chances to share experiences, professional experiences. And thank you for your attention. And I'm sorry for.
That's okay. It happens. Thank you for your presentation and explaining to us how you both learn from each other and developing neurosurgery. Let us go to the next speaker. So, because we're a bit over time. So the next speaker is Professor Thapa. He is from Kathmandu, Nepal, and he's going to talk about twinning, his twinning program with the Netherlands. So the floor is all yours, Professor Thapa.
Thank you, Elian. May I request Dugum to please stop sharing so that I can share my slides now? Yeah, thank you. Okay, so thank you once again, the Global and the Humanitarian section of EANS for giving us this opportunity. And I wear many hats in Nepal, but then nothing is significantly related to this talk, and this is purely education and sharing experiences. Well, I come from Nepal, which has more than 8 of the 10 highest peaks of the world. This is how Nepal is known because of its Himalayas. But then what I would like to introduce you is to the people of Nepal with more than 80 diverse ethnicity and over 123 languages being spoken. We are the land with a lot of festivals and events which is happening around the year. And that's why the people here are much more friendly and people love to visit to see people here. Challenges in Nepal when I'm supposed to tell is always consider.
Sorry to interrupt. Are you sharing your slides? Because I'm just seeing 15 minutes transformation challenges and opportunities.
Yeah, it is being like shared, but then I can again reshare it. Maybe it has
so,
not gone well.
We're seeing a black screen with a
Yeah,
red.
thank you for notifying. Let me do it again. Okay, can you see it now?
Not yet.
Interesting. This is being seen here. I'm sharing the same slide. Okay, let me do it the other way around. Okay.
Yes.
Now, is it okay? Okay, now. Okay, so sorry for that interruption. So we took challenges as the opportunities to be explored. And when we talk of Nepal, it has a population of 30.6 million, and it has recently ascended into low middle income countries from a least developed countries as per defined by World Bank earlier. Even though the health budget which is allocated to us is less than 5%, people have been finding a lot of ways to find the health opportunities. And we are still far off from the ideal 1:100,000 population requirement of neurosurgeons as compared to the worldwide data. But then still, we are climbing up with more than 116 neurosurgeons in the services at present. I see there is definitely an opportunity for the Nepal to catch up with the neurosurgical services to the population. So to give a brief about the milestones of neurosurgery in Nepal, initially it was being done by general surgeons, and in fact it was Dr. D.N. Gongol who started the neurosurgical procedures in the Bir Hospital, Kathmandu, with the first CT scan procured in 1988. And then late Professor U.P. Devkota joined Bir Hospital and started dedicated neurosurgical services after being trained in United Kingdom in 1990s. And then under the supervision of Dr. Mervyn Buggan from US, the neurosurgeon started in teaching hospital in Kathmandu. That was the second set to start neurosurgical services, and followed by which there was Annapurna Neurological Institute and Bharatpur Cancer Hospital. This was the first hospital which came up with the neurosurgical services outside the capital region under the supervision of late Balakrishnan Thapa. In year 2000, and in year 2008, Nepalese Society of Neurosurgery with 17 members started its services, and since then we have not looked back. And then many neurosurgical publications, journals which are being published these years. So when we talk of challenges in the country, it is similar to any other low middle income countries. When we talk of these challenges faced by the public itself, the first and the foremost is the financial. Most of the services are being paid by the patients by themselves, because the insurance companies do not pay for health services here in most of the cases, and the national health services are limited to only government facilities, and even the insurance programs are now being taken up only in the government hospitals. And that's why the patients cannot continue with the long-term treatment if in case it is supposed to be taken off. And there is very poor out of the hospital support, and the poor information about the healthcare care is again another obstacle for the general public to avail the services. And then again, when they talk of the healthcare providers, definitely it's a poor work remuneration which the doctors get out of their long services, the suboptimal working conditions, literally non-existent teamwork, and minimal allied specialty support, which I see these days are improving, but still there's a long way to go ahead. And when we talk of the system as such, there's a poor equitable distribution because of the geographical makeup of our country. We have tall Himalayas and then flat lands. So the people are not geographically equally distributed all over. So that's why the services are also very thinned out, particularly in the peripheries where the services are very basic. But then when we talk of personal endeavors from the doctors per se, from the neurosurgeon per se, because of the necessity, a lot of inventions and discoveries has actually happened in the place. Like we have to provide quality services, but then in the lack of gadgets, like we do not have a good arachnoid knife to start the services. So most of the surgeons before me started using hypodermic needle, and they fondly used to call this thing as a Nepali knife. So you can see how beautifully it works even in a well-controlled hands. And similarly, when we use ultrasound in the intraoperative method, like in this publication of ours, we actually use an ultrasound to identify whether the need of extensive duroplasty and the cerebral mobilization is there or not by using the by visualizing the movement of the tonsils underneath the dura, and then the flow of the CSF through the foramen of Megindy, and then finding it out that you do not need to do these surgeries in every patient, and looking at the resolution of the syringe in the post-op. So innovative use of the available gadgets has been a very helpful thing for all of us. And similarly, because we do not have a very existent PAC system to collage our patient's radiology and to communicate to the on-duty doctors. So we found out a method to transmit this data using Viber, and this was again published and awarded in one of the regional conferences. Similarly, in the ICU settings, because these patients who have undergone cranial or the spinal surgeries because of the conditions themselves are bedridden for a long period, to avoid DVT. So we actually identify a WIMPIC protocol, early weaning from ventilator, early mobilization, limb physiotherapy, and even intermittent application of a thigh-length graduated compression stockings, 2 hours on and 2 hours off. And that could actually decrease the need, the incidence of DVT to less than 3% in our series. Similarly, in our places, since the instrumentation is very costly, so we defined a method of a hemilaminectomy by which we can actually remove the tumors and the cysts through a very small hole and very small osteotomies and laminotomies from the back, and which actually avoids any need of instrumentation in this patient. So again, a very cost-effective method to deal with these pathologies. So we use use ultrasound in a very systematic manner to identify the lesion in the pre-op images, and also to evaluate it in the post-op period, whether we have achieved the target or not. So this is just an representative scan of a depressed bone fracture under ultrasound, how we can make an idea about it, about the foreign bodies. So in the absence of the navigation devices, we could use ultrasound for the guidance, and we can even use a deep-seated paraventricular lesion under the ultrasound through a small corticotomy, as you can see in this video. Similarly, we can even use ultrasound to place a shunt in the ventricle under a direct guidance of an ultrasound when in the absence of navigation. And of course, it comes very handy to localize the spinal lesion after doing the laminotomy, so as to identify the lesion at its correct place. Besides using it in the intraoperative period, we have also defined it to be used in the ICU in the emergency setting, to use it for the resuscitation directly, so that the patient can be given the treatment as soon as possible. And of course, we are using it extensively in our ICUs, where we have found that they have changed the management and created a timely management in almost 1/4 of the patients, which would have been easily missed out if in case we would have only waited for our clinical judgment. And this training has been actually passed on to even to the MBBS students. And what we have found that the short courses and early introduction of sonoscopy or ultrasound usage can actually make them better into use this skill. And we're also using this method in OPD, where we are actually trying to see for the flow of the CSF through the shunt, to actually evaluate whether the shunt is not obstructed in the outpatient department basis. And this has been published recently in neurosurgery practice. Besides this, keeping the patient safe during the surgery had been the primemost thing, because most of the centers still are working with one-man army, and most of the people who are around you may not be the neurosurgical department fellows. So in that cases, it's always better a point to make a checklist. And this is now being routinely followed in almost all the services in all the hospitals in Nepal to keep the patient safe. And of course, the introduction of IONM, image bite guidance, intraoperator CT and MRI. Now, few of the centers have even that in Nepal, and use of ECOG in epilepsy surgery has come up very handy, and most of the centers are having this. In traumatic brain injuries, which is still the most common in Nepal, we are not only using the cisternal drainage, but also using endoscopy to repair the skull base fractures. And this again has become a part and parcel of many training centers in Nepal. Removing the big brain tumors from the CP angle, or doing a big craniotomies, or even for that matter, cerebrovascular surgeries from clipping of the aneurysm to making bypasses, or even keratotomy under local anesthesias or under guidance is becoming much more common these days in Nepal. Spine instrumentations it was not affordable. We have actually started using endoscopy. So endoscopic spine surgeons have taken up a big leap in Nepal, and most of the young neurosurgeons are now getting interested into it. And more than the monoportal, the unilateral biportal endoscopy is becoming much more favorite, and because of the need of lesser equipments and far more agility with these two equipments. And now we are doing UBE discectomies and UBE fusions, and giving patients the very early recovery from the pathology. And this is the patients walking from the first post-op day, ready to be discharged from the hospital. Similarly, we have found that doing kyphoplasty, particularly in the elderly patients with the osteoporotic bone fracture, has helped the patients in a big way. And this is a patient who had a dorsal spine fracture, and this could be not very well seen on an X-ray. So we took this patient in a cath lab. Similarly, in this patient, we are doing an augmentation, anterior body augmentation using a kyphoplasty procedure. And then, of course, the augmented screw fixation in osteoporotic spine. The other thing which has come up recently is an endoscopic removed deep-seated hematomas. So this is a case where we are using ultrasound to remove the hematoma from the deep-seated spaces. And of course, once the endoscope is navigated, then we can even go up to the midbrain. So things are now becoming much more better in sense of the use of the navigation. Now, with the introduction of robots in our place, we are not only using robots for brain biopsy, SEEG replacements, and we're also using for catheter placement and hematoma evacuation. Like in this case of a slit ventricle, we could use robot efficiently to place an EVD inside the slit ventricle for measurement and for management. And similarly, we could use a robot for endoscopic holder for an intracranial hematoma evacuation. From the pediatric services, pediatric tumors are being removed very efficiently these days. And from the endoscopic skull basis surgeries, now advanced endoscopic surgeries are available in the country, from pituitary translocations to even use of the augmented visualizations of the vessel in the case of a craniopharyngioma here. We have been doing peripheral nerve surgeries for the last 2 decades in this place, and initially we did not have a nerve stimulator, so we could not be stopped because we sensed the need of it, and that's why we actually transformed the anesthetic neuromuscular stimulator into a nerve stimulator intraoperative by using a crocodile clamp. And now, since we have a Medtronic stimulator with us, things have become much more easier, and we could give good results to our patients. Having said this, I see that most of the neurosurgeons in my country actually follow the same trend as mine. Most of the people have difficulty in getting trained, and then once they establish, they start their own training program and they go into uncharted territory. But everybody ideas is to go collective and convert this individual achievement into an institutionalized memory by creating a team, by making a dedicated neurosurgical theater, and of course a subspecialization at the part. So it is good to see that the services have now spread outside Kathmandu and going into various parts of the Nepal, and very happy to say that almost all the states in Nepal have neurosurgical centers. And neurosurgical training has also come up in a big way, with almost 12 residents being trained in the country every year. And we have the neurosurgical skills labs also, where the surgeons are getting trained. And not only this training programs are open for Nepalese, but also for non-Nepalese people. And in fact, Maldivian neurosurgeons have been trained in Nepal, and WFNS Foundation courses are being run in almost 2 centers in Nepal, and we share most of the research works. And most of the Nepali centers have also become a part in the international trials, be it a Crash 3, Enrich AF, or the Synapse ICU. And now we are now targeting into subspecialty neurosurgery. And in fact, it is my pleasure to inform you all that in Nepal, the subspecialists in the spine, in endovascular neurosurgery and functional neurosurgery, and even pediatric are being trained so that people can actually get a lot of subspecialty. In fact, the upcoming international meeting in Nepal between 13 to 15 November has been themed as subspecialties in neurosurgery, unlocking new dimensions in care. So we are much more focused in giving a high level of subspecialties in neurosurgery. And COVID has actually taught us a long way, and we have been in a partnership with the government in almost most of the things. And we feel that combining our strength with the ENS for advocacy, education, policy, research, and service delivery would go a long way in providing and strengthening our services in the country. In fact, doing everything like this, we still have a lot of challenges. The rising violence against the doctors is threatening the security of the doctors, and now the consumer court is suing left and right and the doctors in a very hefty amount, even though the neurosurgeons are not being sued till date, but then the day is not far. So this has created a lot of challenges to the medical practitioners, and we can see that almost 34% seats are going vacant in specialist medical studies in Nepal. And even those who have already become doctors in Nepal, almost 21% have migrated over the last 4 years. So in future, we can actually expect a lack of super specialist doctors because most of the people feel that the hard work doesn't pay off in the country. But even having said this, we do have a lot of hope with all those things which have developed over the last 4 or 5 decades in the country. And we definitely feel that by the use of innovative techniques and innovative use of the available gadgets, individually, we have a lot of available opportunities with us. Rather than just talking about the challenges. And by building team and improving the system, we can actually give a long way to make this individual achievements into an institutionalized recovery. And of course, we have to collaborate to solve our problems, share to be efficient and strong. Unless we do not do that, the tools we do not share, we will be actually staying alone. So we have to help the turtle go upside again. So we have to keep fighting, and we all know that neurosurgeons are trained to be fighters. So we have to understand our inner strength. So this is a picture of one of my patients, a Sherpa, who recently climbed Mount Everest 3 times. And he had actually underwent a decompressor on his head, and he still is working and going up on the Himalayas. Thank you for your patience listening. And I would like to invite you all to the Inconason session 5 from 13th to 15th of November being held in Kathmandu.
Thank you.
Thank you for all the impressive cases and how you do things with low resources. So thank you. Let's continue with Dr. Kamalo from Malawi, he founded neurosurgery in Malawi. So this is going to be an impressive talk from him as well. And I'm very happy he's here and he found the time to enlighten us. So please, Dr. Kamalo.
Sorry, I had muted myself. I hope you can see my slide. But now it is not moving. Looks like we can't get this right. Okay. All right. Thanks a lot. So yeah, so the topic was training programs, and I entitled mine to what you get and against what you look for from the training program. So I'm Patrick Kamalo, working at Queen Elizabeth Central Hospital in Malawi. The definition for training was very ably shared by Jamil. That is a sharing of knowledge. But I think he noticed that sometimes you have to share equipment as well. So he made a disclaimer that they are not able to share equipment. So I think there are a few more things that we look for in the training. So hence my title, what do you get and what exactly do you look for? So a brief about Malawi. So Malawi is in Africa. So let me get a pointer. I hope you can see my pen. So yeah, so Malawi is there. So that's in Africa, and Malawi is the small country there. Blown up, that's Malawi. Think like Nepal, we've got a funny geography, very long and slim, which again affects provision of services. So I'm working here in Blantyre, but before we're getting patients from all over the country. So a brief about the country. So we are, I think, pretty small, 120,000 square kilometers, quite overpopulated with about 22 million population. GDP is $480 only per capita. And our national budget for health is $19.24, which is about 4% of our GDP. The comparisons are made there with countries in the EANS. This does not want to work. Okay, so in case you want to visit Malawi, we have a few, I think, attractions. You can see the big five, the elephants, the lions, there's a zebra there, and some beautiful scenery. This is Mount Mulanje, one of the highest mountains in Central Africa. It's quite a beautiful scenery as well. And Lake Malawi is also another beautiful attraction. It's actually a national park on the lake. So I think I'll jump this slide for the sake of time. So the hospital I'm working at is Queen Elizabeth Central Hospital. It was established in 1954. Currently, we have 1,400 official beds. When we say official, it is not strange to find, especially in the pediatric unit, to find 3 or 4 babies on the same bed. So officially, we have 1,400 beds, but we usually overshoot that. We have only 10 critical care beds, 5 for, I think 4 for adults and 5 for pediatric intensive care. It acts as a main teaching hospital for the medical school and other schools which are teaching nurses and other clinical workers in the region. And basically, we're offering everything from primary care, secondary care to tertiary level care. So I think I started my practice in 2011. This is one of the operations that I did at that time, doing, this was a Chiarity compression. That time I had no head clamp, so I had to tape the head, I think, on the head like that. So this is how we started. So this time we were mainly just doing hydrocephalus work. We had 2 operating days in a week. We're sharing that theater with pediatric surgery. And whenever they had like emergencies for pediatric surgery, then it would have to be pushed out. So that's why I said up to 2 operating days. That time we're not doing much, I think, treatment of brain injuries. One, I think we had an MRI scan available, but no CT scan, and it was quite difficult to get an MRI done. Usually it takes 3-4 days before the head injury patient had their scan. And again, we didn't have equipment, and unfortunately, where I trained, I wasn't trained to use jiggly saws and what, so I didn't touch brain injuries at that time. So I think in 2011, there was an opportunity that I think I could go to Norway, where we could see. So basically, my training was funded by Norway government, who was collaborating with our university. So when we came back, there was need that, okay, these people are trained, but if there's nothing for them to do, then they may leave the country. So I was offered an opportunity to go to Oslo to see what we can do. So what was I looking for that time? So basically, my vision was that maybe if I could establish a sustainable center of excellence for neurosurgery in Malawi, hopefully with public-private partnerships, local, regional, and international. There's need to train staff and retain them. That included, I think, salary, which salaries is quite a problem, as we've heard from our friends from Nepal. I thought if we anchor most of our work in research, then probably we could grow faster. And there's also need for infrastructure development, that we should have wards, theaters, neuroradiology, and neuropathology. So the process started this time when I visited Oslo in 2011, December. Then the team from Oslo came to Malawi in 2012 for feasibility, just to see if this thing was possible. And then eventually we managed to get funding from then FK Norway, who basically run an exchange program, and there are, I think, a few supporting structures. So basically, the way this program works is we send our staff to Norway for 6 months, and they also send staff to Malawi for 6 months to help train the staff locally. So we started that in 2013, and those are some of the stakeholders in the process. So when we started, we didn't have any space. So with funding from Norway, as part of the twinning, we managed to renovate some part of the hospital, where we created a high dependency unit, which has 6 beds. This is what you have here. This was like a proper first high dependency unit in our hospital. And I think up to this time, we're still maintaining it almost to the same standards as it started in 2014. We also renovated a theater. As I said, that time we did not have a theater of our own. We were sharing a theater with pediatric surgery. A theater space was available, but there was literally no equipment. So I think, lucky for us, And I think with Oslo, we managed to get all these equipment, all these, I mean, the anesthetic machine. Probably we only had the operating bed, but eventually this is also the one from Norway, the operating microscope. So everything in this theater was shipped from Norway to us. I think had we not have this, then probably up to now, maybe we wouldn't have an operating theater. Yeah, so I think the outcomes of our collaboration. So one was capacity building. As I said, there's exchange of staff between the two places. Supply of equipment. We've gotten a lot of equipment. It's not just what I've shown you here. I think for the HDUs, patient monitors, infusion pumps. So basically, we know. I mean, our friends every 3, 4 years, 6 years, you are changing equipment. So basically, when they're changing, they ask us, "What do you need?" And they ship containers to bring them to us for things that we need. So we can get C-arm and everything that we need, which our government cannot give us. So there's provision of technical support for the equipment that we are getting. Apart from exchange of nurses and doctors, we've also had a exchange of biomedical technicians and engineers who go to also Norway just to see how we can maintain the equipment that they are giving us. Supply of consumables, we also get that. Most of neurosurgery is new in Malawi and is expensive. Up to now, you cannot find desmopressin mineral in the country. So usually we ship it out of Oslo and then bring it. Surgicel, I mean, most of the things that you need, then they're not available. So I think through the collaboration, they try to get us as much as we can. So with time, the hospital is now able to buy us some of these things, but there are some which are literally not available in the country. We have to rely on getting them from our collaborators. There was actually provision of staff incentives for our staff. That was also important to us. I think we have a principle that you work as you earn. And my understanding is, I think the demands of neurosurgical care and the way our staff are paid, it doesn't tally. So basically, we push them that they should do extra work. And with the salaries that they're getting, which is the same salary their friends are getting in the other wards who don't face such demands, it becomes a problem. So I think initially we did manage to convince our collaborators from Norway that they could give a little salary supplementation to the staff that we had, and I think that was working. But when we had more and more staff, we had to stop that when we knew it was not sustainable. So basically now we look at other things, we make our ward look more beautiful. At least we can get them a microwave so that they can use. So it's still a good environment for them to work in than in the other wards, but we need to look at those things. There's support for innovation, which we have also gotten from Oslo. So just, I think to summarize on the exchange program, by 2019, we had 36 Marine staff who had been to Oslo on the 6-month exchange program. This was interrupted by COVID. And then we had 12 Norwegian coming to Malawi before COVID came in. Then after that, I think from last year, we started the exchange program again. And we've also had mentorship from Oslo. I think Magnus is here and some other neurosurgeons from Oslo. They have been coming. So usually I think when we are just starting from 2014 to up to 2018, 2019, because I think from where I trained, I had just qualified and then came back and I didn't have much experience. So if I had like complex cases, which I couldn't do on my own, then I would collect them, 4 or 5 cases, then somebody would come from Oslo to help me and teach me as I operate on cases like that. So supply of equipment, I've said, we also got equipment for the operating theater. At that time, we had problems with oxygen. We were using oxygen from cylinders, which we were buying from outside. And that at times, there were lots of shortage. So we would not operate just because oxygen had not supplied. Through the training program, they managed to get us a small oxygen plant, which could supply 3 theaters. So at least for neurosurgery, we could operate all the time. We didn't have to rely on this sourced oxygen. I did talk about innovation. So we managed to develop an electronic record system. This may not be strange for our friends, but here we are paper-based. And I think in most countries in our region, they have to buy the electronic systems. But for us, I think we developed it locally, and it's working very well. I think for those who have used it, who have been here, I think that they're very happy. It works much better than what most people who visit us say they have in their countries. Staff incentives, I mentioned that, and then maintenance. Yeah. So technical support, I think I've gone, I think, for this. And from the collaboration, we have off-site assistance. I think even in surgery, there have been a few times where I've had to call someone in Oslo on WhatsApp that, hey, I think I've got this of a problem. What do I do? And you get that support from the team. Supply of consumables, I think I've gone through that. I think this also includes our funding comes with a bit of equipment. We use reusable drapes and gowns, and we are always sterilizing them, and they finish quite quickly. And through the support, we do manage to get a supply of to buy some material to make gowns and to make drapes, which makes the system flow a bit better. Support for innovations. I've talked about the EMR system. I think we spent about $20,000, I think, to develop that. Do a network in the system, provide computers, and for the development, and it has been a good quality improvement thing. I think all this led to accreditation that we could start training of neurosurgeons. So from 2018, we were authorized to recruit the first group. The training that we have in this region of Africa takes 6 years. So the first group started training in 2020, and they graduated in 2023. We graduated 2. We've got 1 guy who'll be graduating this year. In total now, we have about 7 trainees in the system. 1 of them is from Liberia. So we're also training international people. This is just a screenshot of our electronic medical record system. As I said, I think it works pretty well, and it has made a big difference, and it really sets us apart from other departments in the hospital, which are still reluctant to use a system like this. Lessons learned, I think benefits of long-term collaborations. I think from the start, our collaboration with Oslo was supposed to be long. It was about 10 years. Now it has extended to 12 years. It should be ending, I think, next year. I don't think it will extend over that. And with time, we are trying to, one, get other collaborations, but also try to get the hospital, the government, to provide most of the things that we've been getting from Oslo. The issue of systems maintenance for equipment has also been important. It has been challenging to maintain most of our equipment, but with this support, they're teaching us to do that. Supply of consumables, staff motivation has been of importance. One other important thing is when our project started in the first 2.5 years, so there was a pediatric hospital, which was Messages Pediatric Hospital, which was built. And then there was also a new stroke unit, especially for the pediatric hospital. I think it was well funded, I think a good thing. But because of the way our project or our collaboration was working, they also requested that they should join this collaboration to help them build capacity in the new pediatric hospital, which has an intensive care unit and operating theaters. So that's just an example of, I think, the impact our collaboration has had locally. And also when the stroke unit was formed, they involved us a lot to show them how we managed to do our high dependency unit and how our collaboration is working. Challenges have been a bit of retention of staff. Most of the staff we have trained have stayed within, but most of the staff are young, so maybe they're getting married, they need to move into different locations. That becomes a challenge. Sustainability of the service after the project, we don't know what will happen, but as I said, we're trying more and more to get the hospital involved, and I think they're responding quite positively to that. There's lack of management team or skills to drive a strategic plan for the unit due to, I think, probably staff shortage or what. It's a bit of a problem. Development of research work and research team, that has been a challenge. I think even with the collaboration, we haven't really managed to do a research profile. We have published a few papers, but probably not to the vision that I had in 2011. Then the other challenge that we have is, I think in our Ministry of Health in Malawi does not really plan for specialty services. So basically what happens, I become interested in neurosurgery, I have to work on my own to make sure that neurosurgery develops. That creates a bit of problem. So I think we need like a strategic plan at the ministry level to see that, okay, what specialties do we need? How do we plan the training? And things like that. But we had issues with space requirements. I was so jealous. I think our friend in Russia that they have a whole hospital just for neurosurgery. I think here our patients are scattered all over the place, which really creates a problem. We should have all our patients in one place. Operating theaters, currently we only have one operating theater. We're doing about 900 cases in a year. We started from about 200, so I've raised up to 900 with only one operating theater. We think we need a second operating theater. We have more neurosurgeons in the country and more work, and we don't have the rest. So if we look at the vision that I had, what is green, blue is what we have managed. Sustainable, so the red is what maybe we're still trying to achieve and we didn't maybe get. So I'm not sure if we're sustainable. I don't think so. The rest, I think, probably we've managed. Research, we have failed to do that. And infrastructure development, again, I think we haven't really done much about that. But so we have made some progress, but there's still some things that we think should have happened, which have not happened. So in this picture, you have the 6 neurosurgeons that we have in the country. That's me there. This guy here and the one at the end, the ones at the end are the second crop. They're trained in Morocco. They're trained in Morocco, and the ones flanking me are the 2 neurosurgeons we graduated from the country. Thanks a lot.
Thank you.
Yeah, thank you. Very nice presentation, Dr. Kamalo. Let me just start already with some questions for you, and then Vicky can have some questions as well, and the audience, of course, as well. Malawi, first of all, I visited Malawi when I was a med student. Beautiful country. Yes, I went to Lilongwe. I have very fond memories of it. And there was a thing that struck me because I was working with a lot of clinical officers. Clinical officers. There was one doctor for the region.
Yes.
But they were doing, I mean, it was gynecology. It wasn't anything to do with neurosurgery. But they were doing a lot of task shifting and task sharing.
Yes.
And, that was new to me as a med student. I didn't even know, that this was a thing. But Malawi has been known for having that integrated in their programs. Is that something that could help with the sustainability and the infrastructure and the pathology, what you're talking about? If that is something that you could use, for example, task shifting, task sharing in neurosurgery, is that something that might be of interest? Or, for example, things like proctoring or telementoring, so using telemedicine and trying to advance things for Malawi.
Yeah.
What are your
I think should I answer that now or take more questions?
Whatever you want.
Okay, I think I can go for that.
You can start with this one.
Task shifting is something that we are fighting with. So even for neurosurgeons, so we had a neurosurgeon who worked in Malawi from 1991 to 2001. When he left, he trained a clinical officer to put shunts, and a number of them, and they've been doing that until I came back. So here at Queen's now, we don't have a clinical officer working in neurosurgery. In the other hospitals, I think they do have. So now I've got neurosurgeons we've got 4 central hospitals of neurosurgeons in 3 of them. two hospitals have got training programs. It's a big problem. So I think even in surgery, so for those of us who do not know clinical officers, so these are more like paramedics. They get 3 years of medical training, as opposed to the 5, 6 years, 7 years of a doctor training. So they don't have enough basic. It becomes a bit of, so when you train them to do the job, they can do the job, but the understanding of the science behind it and what becomes a problem. And in general surgery and other, I think people are struggling that, okay, this is something that we need. I mean, this started when we did not have enough doctors. Now we had a college, medical school from 1991, and there are more and more doctors coming up. So wherever possible, I think we are trying to shift again. I mean, we still, we appreciate the work that they're doing, but we still think that I think wherever possible, it's good to have a doctor or specialist doing that. So like I think in neurosurgery, so far, we are not using clinic officers. For telemedicine and what I think that's something that we think we can do. Again, we still have the clinical officers in the peripherals. They do talk to us. From our electronic medical record system that I talked about, it does have a telemedicine component where we can do video calls and rather you review the patient. The take-up has not been that good. We have issues with internet, bandwidth, and things like that. So I think telemedicine is struggling, but it's something that we have explored. Thanks so much.
Vicky, do you want to ask a question?
Sure.
Otherwise, I'll follow
I
up
would have a
question.
question for Nepal, especially. Very interesting talk, very impressive data shown. My question would be, because you showed that the distances are quite long and it's also very specialized in Kathmandu, is there also the incentive to have twinnings inside one country? So not only having twinning between different countries, but also with more remote areas of the country to do an exchange to train neurosurgeons being more remote in different parts of the country?
Yeah, thank you for that question. And in fact, most of the medical colleges which are operating inside the country have taken up 1 or 2 centers in the peripheral setups to provide services and also training to their doctors. And in fact, I was listening to this great question regarding that shifting. Well, what our experiences have shown that particularly when we talk of neurosurgical procedures, even though we can teach general surgeons to do certain procedures, somehow the complication rates and the selection of the patients and how they monitor the patients after the surgical procedures are very difficult to monitor. And of course, sometimes mishaps do occur. So this has been documented in our places, and that's why we try to make the referral much more faster and speedy in case they are asked for. And we always want to give the patients as much as possible conservative care in their own place, rather than shifting the patients very fast and early. And only in the times when the patients requires a surgical care that the patients is being shifted to these specialized centers later on. But of course, the distances are long, and some places are very difficult to reach. And as you would be well aware, the heli rescues are much more dependent upon the visual guidance. And up in the hills, the weather actually turns bad anytime. So the moment it becomes cloudy, the heli rescues are all are nowhere to be found. So patients do suffer if in case the need requires in the bad hours of the day or in the bad weather. So the problems are still there. So the other thing which we are working out is how we can convey or rather talk on telecommunication basis regarding services which can be provided from remote places in off hours even. So that particular thing is being worked out in many places. But again, we need to have boots on the ground, as they say, even on the peripheral places, so that these services can be offered. So those are the challenges which we are still working with. And I think we need to figure out something more innovative ideas or more incentives to those people who are going to these far-flung places and offering their services.
Thank you. Other questions?
Can I add a couple of words, Vicky?
Yes.
Because we have same troubles in Siberia, because many remote regions and the distance between two towns, non-city towns, maybe more than 1,000 kilometers. And especially in inside of polar circle in northeast area, the almost uninhabited territory, and very difficult to deliver some patient to city, to the surgical department.
It seems there's some problem in the network.
Yeah, I think we lost him.
That's the problem with
Right. Was that question for me?
telemedicine. Connection.
So was that question for me?
No, it was still Jamil talking, but he just froze.
Oh, yeah.
Uh-huh.
Maybe we can continue with other questions.
Yeah. I have another question, which is so Dr. Kamalo, you did your training in Oslo, right? So
No,
Europe.
I trained in South Africa.
Collaboration. The change in climate, not climate as in temperature, but I mean as in the high income versus low middle income. Did the experience add to your to your daily work? Was it more, or did it add more of a frustration, knowing that, you know, in the other country you have everything, but in your own setting it's difficult, and then what you use for certain things, for example, if you have, I don't know, a bleeding, the Surgicel is not there, what do you do then? The collaboration between the two actually different worlds, did that help you in your resourcefulness, or was it more that your resourcefulness helped them more thinking broader?
Let me try to attempt that one. So I think I trained in South Africa, in Durban, at Inkos Abatutuli Central Hospital. So it was a new hospital, and it's more like in the West. So we had everything that we needed: neural navigation, what, everything. And the first problem was the decision to come back to Malawi, because I think I knew if I come back here, I'll have literally nothing. And that was quite a big problem. So eventually, I still came back. And my first 2 years were a nightmare, because I was just doing shunts. And neurosurgery is much more than shunts. And we thought I trained, I think that became a problem. So I mean, I couldn't do craniotomies or what. I think because I loved posterior fossa surgery, that was probably the only few cases that I was doing, like the decompression that I showed, I think a few tumors, and I would use upcut, literally, ronger, to remove the bone for the posterior, in the posterior fossa. So that was quite challenging. So what I gained from there, one was the type of equipment. I think because I was used to, like, I think top class equipment, I also insisted that whatever we are getting here should be top class equipment. So I think the drills that we've been using, I think I should not be mentioning the names, but I think we try our best to do that. On the other resources, so things like Surgicel and things like that, so the skills that I think we've developed, and what I'm teaching the guys is, we know those things are important, but you can't do neurosurgery most of the times without them. So like for most of the tumors that I'm doing, I don't use Surgicel. So if I use Surgicel, I mean, still, I think I'm stuck. And the problem that I have personally, I don't know if you guys face that one. Surgicel comes in here, it comes in two types. There's a nice long one, and there's another small one. I would rather have that small one, because I open and use what I need. You get a very big one, and you just use a small bit, and then you throw away the rest, and the cost multiplies according to the size. So usually before I open Surgicel, I have to think that, okay, do I really need it or don't need it? And really, I think for most of my surgeries, I don't use that. So basically, I've developed tricks to see how best we can. One of the paradoxes I think I had from some friends who are coming from also, so they'll bring a Surgicel, and because they're operating, so you find someone is doing a trauma craniotomy, they're using 7 Surgicels. So by the time they are going, the Surgicel is also gone with them. They're not what's the point of this? So basically, I think we're part to strike those balances in short.
Yeah. You know, so for people that don't know, I was trained in the Netherlands, but I'm practicing in the Caribbean. And for me, being trained in Europe and going to a place that is high income country, but didn't have the resources, I also fell into this, oh, I don't have a microscope, I don't have navigation, I don't have everything.
Yeah.
And then I had this idea, I need everything and it has to be all top. And now I'm going backwards thinking, I don't need that. It's a waste of money. Half of the time it's broken. No one can fix it.
Yeah.
So let's go back to basics.
Yeah.
So, you know, and that's why I like the presentation of Professor Tapa as well, showing all these low resource manners
Yes.
to
Yep.
fix, you know, things that other people have intraoperative MRIs for example.
Yeah.
So, yeah, I think that these types of webinars make us think differently. Sorry, I keep getting messages. So that's why I was very happy to to get this webinar going. And I don't know if there are any other questions.
Jamil is back. Maybe you want to finish the sentence you were starting.
Oh, sure. Yes.
Jamil, you wanted to say something earlier and we lost you.
No, I excuse me for disconnection because I had some troubles, internet
No
troubles,
worries.
but now I'm okay. Yeah.
But you were talking about the distances in Novosibirsk or in the region as well, and
Yeah.
the challenges you have and how you try to overcome them.
We have a system of telemedicine, and some patients from, especially from North Territory, they can deliver it by plane, but this is extremely expensive, and this not systematically, this not routinely, this rare situation, and sometimes our staff they are going to two patients, not patient to hospital, but doctors to patient. Yes, but this unbelievable to imagine the distance more than 1,000 kilometers. This Nepal is a small country, but with high mountains. But here, many plants, but including mountains too. But many plants, but these uninhabited plants. Yeah.
Yeah, but then it's interesting that if I share you the data, that people take almost 2 to 3 days to walk their way from the deserted place, very far from places, from the Himalayas and from the other places to the regions where they can get services. So the whole reason of starting ultrasound in emergency was that to give the patients the earliest care and the best possible way. Because when I started my neurosurgical practice in Nepal, I started with the exclusively neurosurgical center. Dr. Devkota, the late Professor Devkota, had actually established an exclusive neurosurgical center in Kathmandu, and I was fortunate to work with him. And my experience while working with him was the patient used to come even after a head injury, after 2 to 3 days. So can you imagine that? So those are the problems that patients do have to travel a lot, and that's why if we can provide the services at the doorsteps, at least to the center where they are easily accessible to, that would be a great service to them.
Great. I don't see other questions coming up, neither from the audience nor from us. So I think we're already running a little bit late. Eliane?
Yes, we are. And it's probably 2 o'clock at night there in Nepal, or
Yeah, we already
so
crossed the midnight.
you are still awake, and I applaud you for this. And I'm very, very thankful that you could be here. I think it's important that you know, we tell stories from all over the world. And yes, I thank you for all the information you've given us, and I wish you a good night.
Yeah.
Night to you.
Thank you. Good night, all of you. Thank you. Bye-bye.
Time to
Bye.
go to ICU round. Yeah.
Yeah.
Oh my goodness.
Good luck. Good luck.
Okay.
All right.
Bye
Bye-bye.
bye.
Thanks a lot.
Thank
Thanks,
you.
Bye-bye.
everyone.
Bye-bye.
Bye.
Okay, bye.